I'm Dr. Ken Landau. Thanks for watching. Let's talk about asthma. Asthma is one of the most common chronic non-communicable diseases. Affects both children and adults. It's complex interaction of the genes and the environment. It can present with various manifestations. It can be mild, moderate, or severe. Primarily affects the lower respiratory tract. The symptoms of asthma are wheezing and shortness of breath, referred to medically as dyspnea, cough and air hunger, and all of those symptoms should be reversible with a medicine known as a short-acting bronchodilator, and we can monitor that with spirometry. Simply blow into a tube and it measures the amount of air that you can get out in 1 second. If we look at the population, about 13% of Hispanics, 9% of blacks, 7.5% of whites, causes about 10.5 million office visits and close to 2 million hospitalizations every year. It can develop at any age, but most typically during either childhood or early adulthood. Get family clusters because of the genetic component. In children, it's more common in boys than in girls because of the difference in size of the airway, but there's a switch during puberty. So if we look at adults, probably about 20% more common in women than in men. Common throughout the world. It has a relatively high incidence in developed areas and a low incidence in developing areas. So if you go to countries that aren't really developed, the incidence of asthma is relatively low. There's about a 10-fold difference between the high and the low developed countries. And if we look at a person who moves from an area of low prevalence to an area of high prevalence, well, initially the person has a relatively low incidence more in the native land, but as the person becomes acclimatized to the new environment, and certainly in the second and third generation, then the incidence of asthma goes up considerably. The symptoms, they vary during the course of the day. They tend to be worse in the evening and the early morning. They can vary with the season, and there are certain triggers that seem to precipitate asthma. Talk about them in a moment, but it's typically cold or exercise or pollen or food or viruses. So with this wheezing, that's noise that the doctor can hear with a stethoscope. If it's consistently lacking, then the diagnosis probably is not asthma, probably something else. Has to remit with short-acting bronchodilators for the overwhelming majority of patients. So what are the precipitating factors? A lot of precipitating factors. Could be allergies, could be sensitivities or irritants, could be viruses like a viral upper respiratory infection, especially if it's in the first couple years of life. Bacterial sinusitis and exercise, exposure to cold air, to tobacco smoke, either because you're a smoker or because somebody you're around is a smoker. Seems to be higher in lower socioeconomic groups, people who are exposed to cockroaches and have rodent infestation in the home have a much higher incidence, people who are obese and people who lack access to medical care. Now, if we look at childhood onset of asthma, typically we find that it's associated with eczema, sometimes associated with rhinitis or food allergies. Family history often is common. They have wheezing and coughing that develops with viral respiratory infections. And about 1/3 of the children who wheeze continue into adulthood wheezing. Unfortunately, if you develop asthma in childhood and it persists, it may well signal a decline in the pulmonary function over time. Well, it's difficult to make the diagnosis in children because children don't have the vocabulary to exactly say what the problem is. So oftentimes what they do is they just avoid strenuous activities. They don't exercise. They avoid participation in sports. Or sometimes it's irritability or mood change that signals that they suffer from asthma. Now in adult onset asthma, it's more typical in obese individuals, especially in females. We have late onset, can be as late as up to around age 65. It's underdiagnosed. These individuals don't have the atopic condition. They don't have the onset of childhood eczema. But people who have adult onset asthma may have more severe problems, may have more rapid decline in the lung function, especially if they're exposed to tobacco smoke. Well, other common problems that seem to bring on asthma, especially in adults, are obesity, obstructive sleep apnea, and gastroesophageal reflux disease, or heartburn. Those seem to be associated with a considerable increase in the incidence of asthma, and so too are hyperresponsive airways to either allergens or to pollens and dander, or chlorine as in a swimming pool, or pollutants in the air, the sulfur dioxide, diesel exhaust particulates, and viral respiratory infections. And some people seem to be extraordinarily sensitive to aspirin, and aspirin may exacerbate the asthma, may even cause it to be fatal. And then we have some occupational exposure. So occupational exposure in healthcare workers may be exposure to latex gloves, and then we have farmers and animal care workers who are exposed to a variety of substances on the animals, and we have bakers who are exposed to the grains, and then we have the people who are exposed to the diisocyanates in polyurethane industries, and we have people who are exposed to sulfites in foods and in wine. Occupational asthma may make up as much as 5 to 20% of asthma, frequently neglected. And then we have cough variant asthma, where the principal manifestation is cough. And we also have precipitation of the asthma with beta blockers, so medicines that you might take for high blood pressure or to regulate your heartbeat. And often after a thunderstorm, there are actually epidemics of asthma. Well, if we go back and look at the atopic asthma, about 50 to 60% of individuals with asthma have underlying atopic disease. That's childhood eczema or the urticaria or the food allergies. It's frequently relatively severe asthma, starts in childhood rather than later on in life, frequently associated with some rhinitis or conjunctivitis. We know that people who have this atopic type asthma, well, they have some inflammation in the airways, and the inflammation in the airways seems to be associated with a T helper cell. It's a type of lymphocyte, type of white blood cell, and those cells produce a variety of cytokines, and those cytokines seem to cause the eosinophils to go into the lung, seem to cause the IgE, which is an allergy-containing immunoglobulin, to increase in its amount. That's quite sufficient to cause asthma, relatively severe asthma. But then we also have the non-atopic asthma. It's not associated with allergies typically, can be mild or can be severe. It's more common in older adults versus in children, but the evaluation and the treatment's pretty much the same. Can occur at any age in children. When it does occur, it tends to be more in boys, but they tend to resolve over a period of time, especially during adolescence. In adults, it's more common in women and more common in obese individuals. You can have asthma because of exercise. So we call it exercise-induced bronchospasm. Other people call it exercise-induced asthma, especially when you exercise in cold, dry air, or if you're in a swimming pool and you're exposed to the chlorinated pollutants. Well, when you have that, it can cause a condition relatively similar to asthma. Now, once upon a time, it was thought to be separate from asthma, and when it was thought to be separate from asthma, it was thought that you had to have inflammation associated with asthma. Now we know that that's not necessarily the case. Some people develop nocturnal symptoms, so it can wake them up especially in the early morning. And that's because of an imbalance of the autonomic nervous system. There's relatively little of the sympathetic nervous system and a relative overabundance of the cholinergic system. That means the chemicals that are present, tend to cause constriction of the airways. And when they cause constriction of the airways, that's what asthma is all about. Well, asthma has been studied as far as the genes are concerned, and there is no question that it is in part a genetic condition, but we don't have any specific genes that we can say are really associated with it. Now, the cardinal features of the condition are variable airway obstruction. So we have a variation in the caliber of the airway. And that can occur over a time period of seconds to minutes or even days. We get the bronchoconstriction, the narrowing because the airways are surrounded by smooth muscle. We have mucosal inflammation, and then when we have the inflammation, that causes thickening of the airways. And thickening of the airways means that it causes an increase in the resistance of the airflow. That increases the work of breathing in, and that can cause, obviously, major problems. Well, additionally, we have overproduction of mucus. So when you get overproduction of mucus in an airway that's otherwise relatively narrowed, you can see that we can develop problems. Well, you get the overproduction of mucus maybe because of allergies or viruses or bacteria. And then on top of everything else, since the airways are hyper-responsive, they tend to constrict. So now you have the constriction, you have the overactivity of the mucus-producing cells. You have the constriction because of the smooth muscle cells, and you can have a major problem relatively quickly. We've known about the airway hyper-responsiveness ever since Galen in 150 AD. It's virtually a universal problem in asthma. Well, with the hypersensitivity, we also get the airway inflammation. When we get the airway inflammation, that means a series of white blood cells, different kind of white blood cells, affect the airways themselves. And those cells that affect the airways, they produce a variety of chemicals that lead to excess mucus, bronchoconstriction, cause the smooth muscles to constrict. Obviously, all of this causes major problems. So we get, with the inflammation, that accentuates the obstruction, and then we get the edema, and we get the mucus secretion, we get the hypersensitivity, hyperresponsivity, and you can see that it can get to be a mess relatively quickly. And add to all of that the smooth muscle that tends to constrict. Well, how do we look at the nervous system? The nervous system that controls the bronchial tubes is what's known as the autonomic nervous system. In this case, the sympathetic nervous system, which basically is the same thing as the albuterol, that's good, and the other part of the nervous system, the parasympathetic nervous system, that's the acetylcholine, that tends to be relatively bad. That tends to cause the constriction. Well, if we examine a person with asthma, and it's not during an attack, the examination is going to be relatively normal. If the person is poorly controlled, then we have the wheezing and the rhonchi, which are other kind of noises that you have when you listen to the lungs. You can have an increased respiratory rate. You can have something known as pulsus paradoxicus, where on inspiration, the systolic blood pressure decreases more than 10 millimeters. And some people are using the accessory muscles of respiration. Some people can become so low in oxygen that they become cyanotic. Well, in order to make the diagnosis of asthma, you have to have the symptoms and you have to have the airway limitation, but one of those could be absent. But most importantly, if you're going to make the diagnosis of asthma, with the albuterol, you have to have reversibility. So you have the symptoms, 10-15 minutes after you inhaled the albuterol, symptoms seem to be improved to some extent. Now, you have to rule out a variety of other conditions. For instance, you didn't inhale a foreign object, you don't have tracheal stenosis or a mass in your trachea, or you don't have something wrong with your vocal cords, or you don't have certain kind of heart disease or lung disease. It's best to test people either during an attack or after an attack. But the important thing is that our tests aren't specific for asthma. So there's no gold standard for diagnosis. Closest we get is what's known as the FEV1. That's spirometry. That's where you blow out, and you blow out as much air as quickly as you can. The measurement is the FEV1. That's the forced expiratory volume in 1 second. Now, if a person is outside the norms, and the norms are calculated for the age of the individual, the sex and the height and the race, then there's a possibility of asthma. With the bronchodilator, you should increase the FEV1 by more than 12%. increase the amount of air you get in by at least 200 milliliters. And that's very important for the diagnosis. However, the diagnosis isn't perfect, so sometimes the tests are negative. Well, in people who have asthma, it's appropriate sometimes to do an allergy evaluation, maybe allergy tests or maybe blood tests. But it's important to realize that the pulmonary function tests that we do, they don't necessarily correlate with how well the person is doing. So as a result, we tend to have the patients fill out questionnaires. So we want to know what their symptoms are, how they feel they're doing. And if the pulmonary function tests don't seem to reflect the symptoms that the person's having, if there's a discrepancy and there are symptoms that are present and the pulmonary function seems to be relatively normal, then the person needs some intensification, and vice versa. So any kind of abnormality that persists, we need some kind of therapy. Now, what kind of therapy? The goal of treatment is to decrease the impairment, decrease the symptoms, maintain relatively normal activity level, achieve near normal pulmonary function tests, to minimize the associated risk of other diseases and prevent exacerbations, prevent the flares, get rid of the triggers, and have a written action plan. So every individual with asthma needs to have their own particular plan. And if we have a written asthma control plan, what you do when certain things happen, we can reduce the need to go see a doctor by somewhere between 1/3 and 2/3. And that's quite significant. We reduce the absenteeism from work and school. We reduce the amount of times a person wakes up during the night. And associated with all of this, person needs training. You need training on using the meter dose inhalers, those little inhalers that you use that contain the medicine, because it's not intuitive. We also want to treat any kind of comorbid disease. So if you have obstructive sleep apnea or allergic rhinitis or gastroesophageal reflux disease, or hopefully even if a person's obese, we try to address all of those issues. As far as cleaning the household air ducts or using the high-efficiency particulate air filters is concerned, they're not really recommended by the Institute of Medicine. Humidification, well, the humidification can actually put allergens into the air, so whether to use them or not is questionable, but it's best to keep the household humidity to less than about 50%. Certainly you want to make certain that you're not going to be exposed to tobacco smoke. You take sublingual immunotherapy or the allergy shots if appropriate. If it's an occupational asthma situation, obviously, extricate yourself from the area. Aspirin, if it causes a flare, or the non-steroidal anti-inflammatories like naproxen or ibuprofen, then don't take them. Switch over to acetaminophen. If there's mold in the environment, get rid of it. But as far as therapy is concerned, the principal therapies are either to relieve the acute symptoms, that's for short-term benefit. Those are what's known as SABA, the short-acting bronchodilators. And then we have the controllers. And the controllers basically, to start off with, are inhaled corticosteroids. So all people who have asthma should have access to, among other things, the short-acting bronchodilators like albuterol. That's for the acute symptom. If you have intermittent asthma, that might be actually all you need. But you can't rely on just the albuterol if your asthma happens to be somewhat worse. Even though the albuterol is a familiar drug, it's inexpensive, it seems to be relatively safe to control the symptoms. But if you rely on it too much, then it can increase the risk of severe flares, certainly compared to using the inhaled corticosteroids. So inhaled corticosteroids are the medicines that we use principally to keep the asthma under control. It could be medicines like budesonide or fluticasone, different doses for different degrees of severity. Patients benefit even if they have relatively infrequent asthma, should be used every day But unfortunately, we know the adherence to the medicine is relatively small. But if you use the inhaled corticosteroids on a regular basis, you can increase the number of days you don't have any symptoms by somewhere between 7 and 21 days a month. You improve your lung function, improve your peak pulmonary flow, decrease the symptoms, the shortness of breath and the cough and nighttime awakening, just simply by using an appropriate inhaled corticosteroid. Now, if you're not doing well, then we use what's known as intensification. So we add other kind of medicines. And finally, after you're under control, then there's the de-intensification. So we reduce the kind of medicine that you're taking if you seem to be doing well and you're stable for a couple months. Now, with the spirometry and with the clinical information, we can divide asthma into intermittent asthma, occurs a couple times a week or less, mild persistent, moderate persistent, or severe persistent asthma. If you have severe persistent asthma, you need high-intensity treatment, and sometimes you're not even controlled with the high-intensity treatment. Those are severe asthmatics who should probably see specialists. Well, if you have the persistent asthma and you have symptoms more than 2 days a week, then you should definitely be using one of those controllers, the inhaled corticosteroid, at a dose appropriate for the level of severity. So we look at different steps. So there are 6 steps to the treatment of asthma, at least according to the government, the U.S. guidelines. As far as the World Health Organization, there are 5 steps. So intermittent asthma, symptoms less than 2 days a week, the albuterol probably is enough. If you have moderate or mild persistent asthma, then a low-dose corticosteroid, low-dose inhaled corticosteroid, not the cortisone pills, not the cortisone shot. Well, that seems to be pretty good for the overwhelming majority of people. Well, in some individuals, we're going to find that that's all you need. You need the inhaled corticosteroid, and sometimes you need the albuterol. Some people say that medicines like Singulair, that might even be as good as the inhaled corticosteroids, but don't you believe it. Watch the show that we did on Singulair. I don't think that's a very good drug at all. If you have moderate persistent asthma, instead of a low-dose inhaled corticosteroid, you need a moderate-dose inhaled corticosteroid. Or you can take the low dose and you can add to it, instead of a short-acting bronchodilator, you add a long-acting bronchodilator that can work anywhere between 12 and 24 hours. And because some people have difficulty in controlling when they press down on the medicine that releases the puff of drug into your mouth, into your lung. Well, some people don't breathe at the right time. So as a result, there are large volume holding chambers. We call those spacers, and that can improve delivery. That's very important. Now, in people who have more severe asthma and need steps 4 or 5 or 6, those people probably should be seeing a pulmonologist. Those are the people who have the FEV1 of less than about 60. Those people awaken frequently at night from asthma, and they need multiple inhalations of the rescue albuterol every single day. So in these individuals, it's oftentimes a combination of a long-acting bronchodilator with another medicine called a long-acting muscarinic antagonist, or a LAMA. And those drugs may be sufficient. But if a person doesn't have good control with the inhaled steroid and with the bronchodilators, then if the person has an increased level of eosinophils in the blood or an increased level of IgE, that's like gamma globulin, but it's the allergy-containing one, then those are the patients who are potential candidates for the biologic therapies that you hear advertised all the time on the television. That's the Xolair and the Nucala and the Sincair and the Fasenra and the Dupixent. Well, those drugs are extraordinarily expensive. And even though they're advertised a lot on the television, they're not the first, second, or third choices. Remember, those are way down the list. Those are steps 4 and 5 and 6. Well, in some people, taking an antibiotic, a macrolide antibiotic, an antibiotic in the family of erythromycin for a short period of time might be helpful if you have the exercise-induced asthma that might be caused by the chlorine in a swimming pool or the particulates, and the ozone. Well, you can warm up before the exercise. You can wear a mask if it happens to be cold outside. Symptoms tend to begin within a couple minutes of stopping your exercise, so it's probably a good idea if you have exercise-induced asthma, exercise-induced bronchospasm, what you do is 10 or 15 minutes before you exercise, inhale some albuterol. Or in some people, regular use of an inhaled corticosteroid might be quite sufficient, and some people think that the Singulair might have something to do, but again, I personally don't think that drug works very well. So you need to see a specialist if you have significant asthma that isn't under good control. And if you have to use more than a couple courses of oral corticosteroids in the course of a year. You have suboptimal control of asthma if you aren't using your medicines correctly, if you're not adhering to the medicines, if you're exposed to the allergens, or if you're exposed to cigarette smoke, if you have gastroesophageal reflux disease or sinuses, or you have a lot of viral infections, all of those issues need to be addressed because asthma, uncontrolled, can cause significant long-term damage to the lungs. So we don't want you to over-rely on the short-acting bronchodilators, the albuterol. Have to make sure you're using the medicines correctly. But if you still flare and you have the chest tightness or the cough or the sensitivity to being short of air hunger, you can't speak in full sentences, you have labored breathing, inability to lie down flat, you have fatigue, you have a high heart rate or high respiratory rate, you're sweating, you're cyanotic, obviously then you need specialist care, and those individuals probably going to need some of those biologic therapies. Now, in 2010, the Food and Drug Administration approved something known as bronchothermoplasty. That's using radio frequency to ablate some of the lining of the pulmonary tubes. And whether it really works for a long period of time or not, we just really don't know. The short-term studies show that there's some benefit for a period of about 5 years. Well, what's the likelihood asthma is going to persist? Well, if you have asthma when you're 7 years old, if we look at people 19 years of age, so the asthma was present when you were 7, now we look 12 years later, about 20% of the people in remission, about 40% of the people have periodic asthma, and 40% of the people have persistent asthma. You need to be hospitalized if you have difficulty speaking in sentences, if you have profound air hunger, if you can't lie supine, if your FEV1, the amount of air you can blow out versus what's predicted, is less than about 70%, certainly if it's less than 40%, need to be in the hospital because some people with asthma may find that they have an increased risk of death. And obviously that's something that we need to avoid. The risk of death, more in elderly individuals, more in women, more in black population. So anyway, that's a whirlwind tour of asthma. It's a very common condition. It's often associated with a family history, with childhood eczema, with allergies, associated with a variety of triggering factors. Treatment for the overwhelming majority of people going to be the short-acting bronchodilators, medicines like albuterol, oftentimes combined with the inhaled corticosteroids for people who have persistent asthma. But you have to use the inhalers correctly, and that might require using a spacer. Because remember, it's not intuitive. You have to be pretty good about coordination to squeeze down on the bottle and be inhaling at the same time. You have to be taught how to do that. So, unfortunately, for those people who aren't well controlled with the inhalers, then they might need some of the biologics, but the biologics, the kind of advertised quite frequently on the television, those cost several $1,000s a month. Anywhere between $2,000 and $5,000 will be the list price. So the drug companies say, well, we're happy to soak the insurance company for whatever it's worth, and you don't even have to pay the copay. Well, you have to pay your insurance premium, and that's the problem. Part of the reason they keep going up is because we have all of these fancy drugs that are used perhaps not appropriately. Anyway, thanks for watching. If you enjoyed the show, please tell a friend, consider subscribing so you'll be notified as we post new videos. I appreciate your interest. I'm Dr. Ken Landau.